Welcome, everyone, to the Infection Prevention and Transition of Care podcast series focusing on catheter care in hemodialysis. Today, we have a special guest, Dr. Namrata Krishnan, who is the Associate Professor of Medicine in Nephrology at Yale School of Medicine, based at the VA Medical Center in West Haven, Connecticut. She also serves as the Yale and University of Connecticut Fellowship Site Director at the VA. Dr. Krishnan graduated from Lady Hardinge Medical College in New Delhi and completed her internal medicine residency at University of Connecticut, followed by a fellowship in nephrology at Washington University in St. Louis. Since joining Yale in 2010, she's been a dynamic educator and clinician, deeply committed to medical education, including e-learning, renal physiology, hemodialysis, hypertension, conservative kidney care, and more. She's developed multidisciplinary nephrology palliative care pathway for veterans at the VA. She is a recognized leader in curriculum innovation. She has won the ASN's Innovation in Kidney Education Award for her Hemodialysis Access 101 module. Today, Dr. Krishnan will discuss about best practices about catheter care in hemodialysis, as well as bust some common myths around hemodialysis catheter care. So welcome, Dr. Krishnan, to this podcast.
Thank you so much, Dr. Chopra, for the kind introduction and to the ASN for this invitation. It's my pleasure to be here.
Please call me Tushar, and I will dive straight in. Namrata, why is infection prevention in dialysis care so important? Why should we focus on it?
Yeah. So I think when we think about the dialysis unit and our patients, I think infection risk is like dialysis unit is the perfect storm, I think, in terms of the risk of infection. So when we think about our patients in the unit, most of them are at some level immunocompromised. They have, a lot of them are elderly patients. A majority of them are diabetic because diabetes is the leading cause of kidney disease worldwide. So it's the perfect setup in terms of patient factors that predisposes them to the risk of infection. And then when we think about what these patients go through in the dialysis unit in terms of having their blood exposed to multiple different contaminants, potentially to airborne infections, it just forms the perfect setup for these patients to end up with severe, sometimes bloodstream infections. And then when you look at the cohort of dialysis patients and see which of these patients seem to be the most susceptible to infections, I would say it would be our patients with dialysis catheters, and especially those that have chronic dialysis catheter use. Even having a catheter for 3 to 6 months predisposes these patients to infection, and the longer you have the catheter in, the higher the risk of infection is. So and as we all know, people, all of us that provide care to patients in North America, we know that at least in the United States, 80% of new dialysis patients start with a dialysis catheter. And then when you look at the prevalence of these catheters in patients, it can range anywhere from 20 to 50%, depending on where in North America you're looking at. So in other words, we have patients that have high risk of infection because of their own patient factors, plus the catheter use really predisposes them to even higher risk of bloodstream infections.
Yeah, no, thanks for sharing the stats about, the high prevalence of catheter rates. Sounds like, we have to work around it and just have better infection prevention strategies around dialysis catheter. So could you help me walk me through how to, safely maybe connect or disconnect a patient on hemodialysis to improve our catheter care?
Sure. Yeah, so I have to start this section by giving all of the credit to our dialysis nurses and dialysis technicians because they are really at the forefront of doing the day-to-day care of these dialysis catheters and, involved in connecting and disconnecting patients. I think as nephrologists, we tend to take sort of a back step and let the experts do that part of patient care. But in general, I think when we think about connecting and disconnecting patients, every unit has their own specific protocol that they tend to follow based on their practice patterns and based on their infection patterns. But I think that when you look at the principles that guide these protocols, the three main things that we should think about when we're handling catheters and connecting patients and disconnecting patients from machines is to have immaculate hand hygiene and personal protective equipment. So I think that is the number one priority when we as providers are handling catheters. Number two is ensuring that there is absolute aseptic precautions that are used when we're actually handling the catheter. And this then includes catheter care processes, which the CDC has very nicely outlined as the scrub the hub protocol, and there are several others that exist. But in essence, the provider needs to use hand hygiene and personal protective equipment, know how to take care of these catheters and clean them before connecting and disconnecting patients and after connecting and disconnecting patients. And then third, using very step-by-step protocols to actually do the cleaning process. And so I think step one is always going to be washing your hands with soap and water if your hands are, dirty, or you can use an alcohol scrub to clean your hands thoroughly before you wear your gown, your mask, and a face shield if that is something that you are choosing to use, which is highly recommended because we are exposed to blood products while we're handling patients. The patient also should be wearing a mask at the same time to lower the risk of airborne contamination of any of these surfaces. Once that is done, there are aseptic kits that are available to use that help to provide all of the things that you might need to safely connect and disconnect patients. And so part of those kits are sterile drapes. There are alcohol-based chlorhexidine swabs that are included in these kits, which is what the CDC recommends to use to scrub the hubs of the catheter very well, both hubs with separate alcohol-based chlorhexidine swabs. And then once these are cleaned, and they should be cleaned for 30 seconds each, we have actually clocks in our dialysis unit just so the technicians and nurses can watch the amount of time that they need to use to scrub these. And once that is done, then to implement aseptic precautions to make sure that these clean hubs are not touching any contaminated surfaces before connecting the blood lines to the catheter. And a part of this should also include dressing changes to the exit site and examining the exit sites to ensure that the exit site appears clean and not infected. And we can sort of go through the steps of that too, if that is something that you'd like me to go over.
Thanks for this. Scrub the hub technique is very important and it's a game changer. I agree with you. And what we do over here is we make the patients count. So they're counting 1, 2, 3. So it's a way to engage the patients.
Yeah.
And you're right. You have to spend that 15 seconds each in scrubbing the hub, and we should not be taking shortcuts.
Right.
And poor connection technique is one of the top modifiable risk factors in our CDC core interventions for bloodstream infection prevention. So yeah, the tidbit that we do is we tell the patients, you count, and the tech or the nurse has to do it slowly.
Yeah, well, that's a great idea too. It makes the patient advocate for themselves, which is so important.
Yeah, no, and maintaining a closed circuit, which is so important. So any suggestions on hygiene practices or protocols pertaining to dialysis catheter care, beyond the unit protocols, any kind of standardized training, auditing, education?
Yeah, so I think that, again, the CDC has outlined several protocols around safe hygiene practices. There is a lot of great publications out there discussing these as well. I think some of the big points, that sort of come to my mind are using, again, personal protective equipment, and then chlorhexidine has been a game changer, as you said, using the chlorhexidine-based scrubs, not just for hub cleaning, but also for skin prepping and then skin dressing, has really significantly lowered catheter-related bloodstream infections. So that would be something to really think about. I am actually not sure if there are any specific protocols that you were alluding to that we should discuss. But I think in general, these are sort of, some of the practices we use in our dialysis unit, specifically with regards to using chlorhexidine scrubs for 30 seconds at the end of the treatment prior to changing the dressing. I think that is, again, something that has been really successfully used and has shown to dramatically lower catheter-related bloodstream infections.
Yeah, and I think you were alluding to the cluster randomized trial that had come out in Jason, where there was 56% reduction in
Yes,
related.
exactly. Back in 2017, I believe it was. Yes.
Perfect. Yeah. What we do, we are trying our level best to educate patients on how to take care of their catheter on their own, just like we would do in a home hemodialysis setup. Because, one of the CDC core interventions is to educate the patient. And
Absolutely.
I don't think we do a great job. And as a form of patient engagement, we try to train our patients how they should take care of their catheter at home. And so it's like the patient education on home hygiene, if applicable.
Yep. Absolutely. I think, like you said, patients spend more time outside of the dialysis unit than in the dialysis unit. And so really engaging them and having them actively participate in helping us prevent these infections is really the key to achieving this goal as a whole, I think, because the dialysis providers can only do so much. And as much as their training is important, I think patient education and patient training is equally, if not more important. Absolutely.
I agree. And I think I'm always trying to bust some myths that patients may have. So, are there any common myths that exist around catheter care and hemodialysis? And is there any evidence that is for or against it?
Yeah. So I think the first thing is exactly what you just said. The biggest myth is that it's really the job of the dialysis providers to prevent infections, whereas I think the truth is it is the job of the patient and the dialysis provider. So that certainly is number one and most important. I think there are a lot of concerns around personal hygiene practices among patients with a catheter that are receiving dialysis via catheter, because in general, the recommendations historically have been to recommend no showering, certainly no swimming, not allowing the catheter site or the dressing to get wet. And although these recommendations are built in good science, it is a big quality of life issue for a dialysis patient to be told not to shower. And we know, based on, I think, anecdotal experience, and also this recent study that was published just a couple of months ago in AJKD that reviewed a survey data set across Canada and looked at, what are the practices around showering with dialysis patients, what the providers are saying and what the patients are doing. And what they found was that 75% or higher providers recommend against showering, and 50% or more patients are aware of this recommendation, and yet almost 75% or higher patients continue to shower. And so what that study shows us is that really, as much as we are concerned about infections, we have to really pay more attention and give more importance to patients' quality of life and satisfaction aspect of care as well. And so there have been some studies that have looked at specific showering techniques and how perhaps that might allow for a safer procedure in terms of showering and continue to allow the patient to have good personal hygiene based on their own priorities, but also minimize the risk of infections. And so some of these studies, I recall one that was published back in, I believe it was 2016 or 2017 again, where it was called the HIPPO-ST trial, where they looked at specific showering techniques and randomized patients to standard recommendations of no showering versus teaching them how to actually shower, and then also to examine their own dressing and then change their dressing if it did get wet, which really with that, in that study, it showed there was no real difference between the risk of or the incidence of catheter-related bacteremia in the two groups, showing us that if done correctly, and if patients are trained and educated correctly, that you can actually go through something as simple as allowing them to shower and not increase the risk of infection. So I think that is something that comes up often, and it is something that we as providers really should try to educate our patients about and teach them how to shower if they're going to do it, right? I think that we know swimming is probably certainly a no-no, because you can't effectively protect your dressing if you're going to be submerged in water. But showering certainly seems to be something that is okay to do if it's done right.
Yeah.
Mhm.
Yeah. And, I was going to say, are there any waterproof dressings or any recommendations that you give
Yeah.
your patients?
So there are waterproof dressings and there are waterproof tapes, both that I think if a patient is going to shower, I think some of the things to think about is one, you really want the exit site to be completely healed before you allow a patient to shower. And how long does an exit site take to heal after a catheter is placed can vary tremendously between patient to patient. And so, there is really no set time, I think, to say, okay, it's been 3 days or it's been 3 weeks and you're okay to shower. I think you really have to examine the exit site for that specific patient and ensure that it's fully healed. There's no redness, there's no swelling. And again, the dialysis nurses and technicians can also be your aid in that to help assess that exit site to ensure that it's ready and fully healed. Once you've ensured that it is so, then you can prescribe these waterproof AquaGuard dressings that you can place over the catheter. You also want to ensure that the hubs of the catheter are also encased in a waterproof sleeve. And then the tape that you use to attach these should also be waterproof, because when the patient is in the shower, you really don't want any water to seep through beyond the tape. The third thing that we recommend we tell these patients is to ensure that they're not using a direct stream of water directly on the catheter site. So if they have the ability to use a handheld shower, that's always best. And long showers maybe are not so great. Maybe, they can get in and out quickly and keep the time in the shower less, because the biggest concern with showers is that if the dressing gets wet, even if it's a little bit of moisture, it can be a breeding ground for microorganisms, and it does increase the risk of infections pretty quickly. So we like to keep this dressing completely dry at all times and clean. And so once they're done with the shower, we tell them to pad dry and not rub around the tape, so that they're not pulling the tape off in any accidental way. And once they've pad dried, they can carefully remove that waterproof barrier that they've placed and examine the dressing to make sure that the dressing is still dry and it's clean. If it's not, then these patients should be given an emergency kit so that they can actually do their own dressing changes. And one could argue whether that's a safe thing to do or not, whether we should allow our patients to change their own dressing. But then when you think about patients that do home hemodialysis, when you think about patients that are cannulating themselves, right? I mean, we allow that level of expertise in our educated patient, or a patient that is able to develop that sort of skill, teaching them how to change their dressing just empowers them more. And I think it actually allows them to keep things safe and clean. So allowing them to do that, teaching them how to do that, I think is a great idea. And if a patient insists on showering but doesn't want to change their dressing, sometimes timing the shower right before they come to the unit could also be helpful, right? And then the nurses could help change it. But I think in general, we really want to empower our patients and teach them how to do it themselves. So those would be some of the tips and tricks, at least, that we try to use in our unit.
And no, thank you, Namrata, for sharing that. And there's probably never going to be a randomized controlled trial around this shower question. And thanks for sharing your tips on, protected showering and prompt dressing change. And I like your idea of empowering the patient and, teaching them to be part of the team and enable them to do a safe dressing change. So that definitely deals with the shower question, and a lot of patient engagement and empowerment can come out of this. Some other myths that I hear from patients a lot is the mask use is optionals. What are your thoughts about the mask policy in the hemodialysis unit?
So I think that so I would disagree. I think mask is not an optional thing. Even now in our unit, outside of just catheter changes and hook up, disconnect and connect, we still actually use masks universally in our dialysis unit. It's one of the few places in our hospital that mandates masks. And I think that masking really does prevent, to some extent, the airborne contamination of exposed surfaces, especially during connection and disconnection from the machine. So I think that mask is just one more layer of barrier protection. It does also, if there's any spills, if there's any, blood shooting here and there, which should never happen, but we all know that it can. I think that a mask just protects the face from any blood contamination too. But I think even in the absence of that, there are several airborne infections that can transmit, without a mask. So that I think is still very important. Another thing that I just want to add, I think in terms of myths too, is that a lot of people expect patients to develop a fever when they get infections and forget, especially I think trainees, this is an important point for the trainees, that catheter-associated infections can present in many ways, and fever and chills, which is the textbook way we expect them to present, may or may not be the case. Sometimes the patients could just be a little more lethargic or weak or, have altered mental status. And I think that anything unusual in a dialysis patient with a catheter should, even in the absence of fever and chills, should really prompt checking blood cultures and ensuring that someone's looking at their exit site and their tunnel to make sure that there's no infection issues going on, because we actually all know that bacteremias can occur even in the absence of exit site infections, and that's typically how they present. So even in the absence of a tunnel tenderness or erythema at the exit site, something that's out of the ordinary in a patient with a catheter, I tend to always check blood cultures just to make sure.
Thank you for busting some of the myths that we have around the mask policy. So yeah, CDC does recommend strict mask policy to show reduced catheter-related bloodstream infections. You explained to us about protected showering and prompt dressing change, and how infection related to the catheter can have a very silent presentation too. So always keep that in the back burner. Are there any emerging studies or evidence that challenge the existing beliefs about the best practices around catheter care?
So I think one of the emerging studies, I would say it's now about 5 or 8 years old, is using chlorhexidine impregnated caps as sort of the last layer of protection when we send the patients out. So we typically use standard caps in a lot of the dialysis units at the end of the aseptic precautions and scrub the hub and clean and everything. However, there are newer sort of caps that have chlorhexidine impregnated rods within them, which have been shown to be extremely effective in lowering the risk of catheter-associated infections almost by 50% or higher in a lot of the studies. And so that seems to be a very effective method of lowering catheter-associated bacteremia. What's nice about chlorhexidine also is that it is not an antibiotic. It's an antimicrobial that somehow does not seem to increase the risk of resistance within the microorganisms. So with a lot of the previously used antibiotic lock solutions and such, there has always been this concern that using antibiotic lock solutions can increase the risk of antibiotic resistance in microorganisms. And with chlorhexidine, because it's not truly an antibiotic, we don't seem to see that happen. And it is a very effective agent. So that would be one aspect. There is a push to use citrate locks over heparin locks because there is the thought that citrate has anti-infective properties, and although both citrate and heparin decrease the formation of the biofilm, which can be the breeding ground for a lot of the microorganisms that then lead to bacteremia, that citrate is more effective in allowing because of its anti-infective properties, allowing lowering the risk of infections. That is a controversial topic. I think that theoretically it makes sense. In some studies, citrate has shown to lower the risk, but this doesn't seem to pan out in all of the studies consistently. So that is something that is not consistently used. But in our unit, we do use citrate locks routinely on all patients with catheters. And I mean, we have had a very low risk of infections in our unit. I think we had 0 in 5 years until that streak broke with one specific patient that had a lot of patient-related issues. And routinely, we have been using the chlorhexidine impregnated caps, and we have also been using citrate locks. And I think both of that has actually made a huge difference. There is also a push in some of the recent studies to use a patch, like a chlorhexidine impregnated sponge that you can put at the site of at the exit site. That hasn't shown as impressive results as some of the other chlorhexidine data that's out there. We do tend to use the sponges too in our unit for what it's worth. And then lastly, some places that don't use these sponges, the chlorhexidine sponges, do tend to use antibiotic creams topically at the site of the exit before dressing changes, and that has shown to certainly lower the risk of infections. However, then there is the concern around antibiotic resistance using those creams on a regular basis. So again, I think, we always, when we make these decisions and make unit protocols, we're always thinking about the risk and the benefit of some of our interventions. And for me personally, I think chlorhexidine seems to be taking the win on many accounts for a lot of reasons.
Well, thanks. And, just to follow up on the heparin, on the citrate lock that you mentioned, is the concept just to prevent fibrin sheath, which will then reduce risk of occlusion and maybe infection? And
yes, and then citrate has its own specific antimicrobial properties too, in addition to the anti-fibrin sheath effect, because the anti-fibrin sheath effect is an effect that's seen with heparin too. But heparin has bleeding risks associated, and citrate doesn't, or does not as much. And then the citrate as a molecule has some antiseptic properties innate to it, is at least my impression or my understanding, which heparin does not. And so that seems to be more favorable towards citrate use.
That's great. Thanks, Namrata. And you shared a lot with us. You've busted some myths around catheter care. You've walked us step by step about safe connection and disconnection. You've educated not just the providers and fellows, but also the nurses and patients, if they are listening. So, if our listeners had to remember just one thing from today's podcast, what should it be?
I think the one thing would probably be patient and provider are equally important in preventing catheter-associated infections. And catheters are here to stay as much as we would like them to go. I think the whole fistula first push was amazing. However, I think the catheter last policy seems to make more practical sense. I think universally, because we know there are patients that are not candidates for catheters or are unable to, or excuse me, candidates for permanent access. And so it is our job as dialysis providers to really understand how to best take care of those catheters that will remain with us for the foreseeable future.
Well, thanks, Namrata. Very well said. It's patient-provider partnership in preventing dialysis catheter-related infections. And with this, we thank you for participating in the podcast.
Thank you very much.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.